Today we are going to be talking about a case of dementia improvement after plasma exchange for familial hypercholesterolemia. This case was published in 2016 in Case Reports of Neurological Medicine, a peer-reviewed open-access journal. Worldwide, dementia-related memory issues affect a great number of patients and families. In this case, a senior moment was noted at age 50, and issues with memory and mind progressed, resulting in an early retirement from work. The patient described here was given a diagnosis of pre-Alzheimer's disease and presented for further accurate evaluation, diagnosis, and management. The medical management resulted in an improvement in the patient's memory and cognitive ability. Introduction. Dementia and cognitive function loss from a variety of etiologies are common. Familial hypercholesterolemia-related elevations in low-density lipoprotein, LDL, are often challenging to treat. This case describes some of the changes in cognitive function that were observed over time. Case. At age 15, she had syncope and collapse where no diagnosis was made. At age 50, the family noticed the first problem with memory. The patient purchased and picked up a birthday cake from a local bakery. Yet later the same evening, she asked who brought the cake, apparently unaware of the day's events. Through her 50s and 60s, a steady variety of cognitive difficulties were noted by the family and the patient. Being an avid reader, she became frustrated with an inability to remember character development. On her own, as a memory tool, she started to write character attributes into the front covers. The patient began to have difficulty with ordering meals from menu selection. She was unable to properly purchase a list at the grocery store, often returning home with items missing. At age 62, she was treated with a lumpectomy and radiation for breast cancer. Around that same time, she was placed on medication for an elevation of LDL due to familial hypercholesterolemia. At age 67, she began to notice difficulties with remembering product codes related to her job. 2 years later, when the difficulty with work progressed due to issues with her memory, she retired. Her medical team explained that she had symptoms of Alzheimer's disease. At age 71, she presented for evaluation of issues with memory and mind. Her medications included Crestor 40, Celexa 10, aspirin 81, and Zetia 10 milligrams. Presenting LDL on medications was 220. There were no other significant hospitalizations or medical diagnoses aside from the ones mentioned. She did not use tobacco in her life. The family members were also affected with hypercholesterolemia. Their father passed away in his 50s from a sudden cardiac event. The children are known to have LDL levels over 500. Younger sister, after loss of driver's license, had completion of neuropsych testing and was given a diagnosis of cognitive loss due to pre-Alzheimer's disease. Physical examination provided a well-developed, well-nourished elderly female, blood pressure 120/74. Eye exam revealed corneal arcus without the presence of xanthelasmas. Auscultation revealed 3 out of 6 mid-systolic cardiac murmur and bilateral carotid bruits or transmitted cardiac murmur sounds. Flattening and asymmetry of buccinator movement with preserved function, cranial nerve 7. Enlargement of thyroid, possible nodule, and metacarpal phalangeal joint tendon xanthomas. Medical evaluation revealed brain MRI findings of enlargement of bilateral ventricles, loss of neuronal mass, enlargement of cerebral cortex sulcus, and shrinkage of gyri, periventricular and posterior flare signal changes, along with numerous isolated signal changes. A 24-hour Holter monitor recorded rare, non-sustained ventricular tachycardia. Two-dimensional echo revealed the following: 26 mm aortic root with calcifications, sclerotic trileaflet aortic valve, calcified thickened mitral valve with mild insufficiency, left atrium diameter 37 mm, ejection fraction estimated at 60%. Non-invasive myocardial perfusion imaging testing was completed and reported as a homogeneous distribution with no perfusion deficits. Doppler ultrasound revealed 20 to 49% bilateral carotid artery stenosis. A thyroid ultrasound found homogeneous enlargement of the gland without any discrete nodule noted. Apolipoprotein B was 115, ANA negative, homocysteine 8.99, uric acid 3.7. Factor V Leiden, positive mutation, R506Q. Factor II, normal. Homozygous MTHFR C677T mutation. APOE genotyping resulted in an E3E4 finding. The following additional genetic testing was completed in this case: PC3K9 defects, and the following were noted. Otherwise, the patient had normal renal, thyroid, and blood chemistries. Independent neuropsychological testing and interpretation diagnosed memory loss and vascular dementia. The patient had weakness in verbal memory, as well as visual and design memory, and verbally mediated executive functioning. Testing also added adjustment disorder with mixed anxiety and depressed mood. After updating all patient data and gathering information, a large decision tree existed with multiple management options. Example, factor V, homocysteine, the carotid artery stenosis. The difficulty in medical management of familial hypercholesterolemia and familial combined hyperlipidemia has been previously described. Initial patient management included a drug-free period and follow-up lab data. After 4 weeks, there was a significant elevation in LDL. The patient's untreated LDL was 351. Maximum lifestyle, diet, and medications, including Crestor and Zetia, were not effective in achieving a lower LDL. After ruling out many of the easily identified reasons for cognitive decline and accepting that a more obscure diagnosis could be possible, the patient wanted to complete a period of LDL mitigation and observation. The patient and family made a decision to treat the elevated LDL not responsive to current medical management with selective lipoprotein apheresis. Selective LDL apheresis equipment was not geographically available at the apheresis clinic, and the patient was offered plasma exchange as the best available geographic option. The patient started plasma exchange sessions shortly after. Therapeutic plasma exchanges were carried out with an automated blood cell separator. Peripheral intravenous access would be obtained, and 2451 ml of 5% albumin and 180 ml of normal saline would be exchanged during therapeutic plasmapheresis. A goal of 35 ml per kilogram of plasma was removed, and the geographically available facility would use normal saline in addition to volume replacement. There were never any reported or perceived complications or side effects of the treatment sessions. After 2 years of plasma exchange with 5% albumin on an every 3-week schedule, the patient's LDL range was 46 to 114. Cognitive improvement was gradual, but after years of specific events were described. The patient was able to go to the store with a list of groceries and bring them all home. Interaction with restaurant menus no longer became a challenge, and the family noticed this as the most striking compared to the past, where the interaction of selecting from a menu and communicating that was difficult. The patient explained that she had less problems with her books, being able to follow a detective story from the beginning to the end without taking any extra notes. At 27 months, a follow-up carotid artery duplex vascular ultrasound was completed by the patient. Comparisons of the velocities showed some improvements. Discussion. The patient's initial presentation is a common one, where memory issues are noted by a patient and family, yet the issues are challenging to measure, grade, score, or judge to any degree of certainty. The finding of an LDL elevation is not uncommon. After medical management, patient's choice of apheresis was safe and effective treatment. Access to repeat neuropsychiatric testing would have been helpful, but geographic and insurance issues limited patients' access. There are guidelines for the use and indication of lipoprotein apheresis, along with a debate on the same guidelines. Guidelines for use of lipoprotein apheresis that do not include any indications of data obtained from the level of APOB could represent an area of interest. Limitations. In this case, there may have been added benefit from more frequent sessions. However, the patient's balance of lifestyle and access did not afford more frequent sessions. Using the interactions of daily affairs as observed by the patient or family as a marker of changes in cognitive ability is challenging. Examples: success with grocery lists and interactions with menus. Yet in this case, there is enough improvement for the family and patient to provide extremely strong feedback of improvement that it deserves description. There could have been other lifestyle or physiological reasons that contributed to the improvement in cognitive ability that remain unidentified in part or in whole. For example, effective plasma exchange on factor V genetic mutation, homocysteine, fibrinogen, coagulation, or endothelial vasodilatation. Therapeutic plasma exchange inherently provides a significant non-lipid anti-inflammatory effect, useful across a plethora of disorders. The removal of pro-inflammatory factors, including complement, coagulation factors, cytokines, and endothelial adhesion molecules, may provide additional benefits beyond the LDL reduction. With the removal of intravascular plasma proteins, other authors have shown variable results in response to therapeutic plasma exchange. While it remains elusive to place an exact time on the improvement, as cognitive ability has many different associated factors, yet family and patient, after 2 years of treatment, report a significant improvement in her day-to-day function. She was again able to read books and literature. She was able to properly plan and handle family events. Daughter present at each visit would report remarkable ability of the patient's recall on a daily basis. Many more attributes of the unique individual are unable to be accurately evaluated that may be perceived as significant cognitive improvement. Examples of self-confidence, mood, compassion, curiosity, empathy, concentration, enjoyment of life events, and creativity. During a visit at 3 years of treatment, the patient reported that she was continually able to read her detective books without the need to place notes and reminders of the characters in the front cover. These attributes may contribute to the cognitive ability of the brain to function at an improved degree. Data such as the LDL, neuropsychiatric scores, brain atrophy are better suited to be measured, graded, and separated into scientific categories. Many have described the expected course of a patient diagnosed with Alzheimer's, yet there remain fewer described cases of improvement after that diagnosis. Others have described reversal of dementia. This case may deserve wider attention, as this is a common patient population. Similar patients have been described who are left with inadequate therapy without access to lipophoresis. Prevention of dementia and improvement in cognitive function remain obscure and difficult, as there are no good tests of what makes up the attributes of a unique individual. Disclosure: Dr. Urich operates the Dementia Prevention Center, Music, Pennsylvania, and holds a U.S. patent on the method for the prevention of dementia and Alzheimer's disease. Competing interest: there is no conflict of interest to declare regarding the publication of the paper. References: Thank you. This is a case report of dementia improvement after plasma exchange for familial hypercholesterolemia, published in Case Reports and Neurological Medicine.